Okay. So emerging JAK inhibitor combination treatment strategies in myelofibrosis. So we know that patients treated with ruxolitinib have a marked effect on 2 of the 3 main manifestations of the disease, the symptomatic splenomegaly, the constitutional symptoms, also in other manifestations, for instance, the pruritus. But in general, the effect on the anemia is not very evident. Actually, the patient, especially at the beginning of the treatment, had a worsening in the anemia. So this is an aspect which is not well controlled by ruxolitinib. And as I had mentioned before, concerning the reduction of the JAK2 allele burden, there is individual patient in which there is such marked reduction, but in general, the reduction, I would say that it is modest according to the data of the 5 years follow-up. Also, here, the effect on the fibrosis. So clearly, there was an important proportion of patients in whom there is an improvement in the fibrosis, but there are other patients in which there is no improvement or the fibrosis is stable. So overall, this is not an overwhelming effect of ruxolitinib. And this applies to the other JAK inhibitor. In general, these drugs are highly effective in controlling the spleen, in controlling the symptoms, not only the spleen-related symptoms, but also the constitutional symptoms. With ruxolitinib, as I had showed before, there is a prolongation of the survival, but no clear effect on the JAK2 allele burden, and in general, no clear effect on improvement of the anemia. So, problems? Next, okay. And because of this, currently there are some attempts to combine ruxolitinib with other drugs. The first kind of combination is aimed at improving the aspect which is not well covered by ruxolitinib, which is the improvement in the anemia. And ruxolitinib is being combined with different anemia-treating agents, such as erythropoiesis-stimulating agents, androgens, such as danazol, immunomodulator, lenalidomide, pomalidomide, and other drugs. The experience is very limited. Actually, although in practice we are combining ruxolitinib with erythropoiesis-stimulating agents, there are virtually no data in the literature. The only, to the best of my knowledge, the only available data comes from the COMFORT-2 study in which a minority of the patients, 13 patients, received these agents in combination with ruxolitinib. And half of the patients had an improvement in the anemia. The improvement was seen early, in a few weeks, and this has no effect on increasing the spleen size. So this combination is possible, especially if patients had inadequate EPO levels. So not in patients with very high EPO levels, but so this is something with limited data, but that can be used in this situation. I don't know why. So, next time. But as I have mentioned before, there are other studies, all in a very preliminary stage, combining ruxolitinib with danazol, with pomalidomide, and with lenalidomide. Concerning the data, the available data, we know that in the case of lenalidomide, there are problems, and the main problem is the development of cytopenias, mainly thrombocytopenia. And this led to the stop of lenalidomide in most patients. So apparently this seemed not to be a good combination. With pomalidomide, very limited experience, a few patients, so some side effects, but we cannot say anything else because the number of patients is very low and the follow-up very short. And The same applies to danazol. There is a study combining danazol with ruxolitinib, few patients, and for the time being, very preliminary results, the benefit seems to be modest. Also, in practice, we are using danazol in combination with ruxolitinib, and in my experience, there is some patient who clearly responded, but this is based on personal experience and isolate patients. But we know that in addition to the JAK pathway, there are other targets that can be subject of therapeutic target for myelofibrosis. There are many other targets, and based on this, there is a rationale for combination of drugs in this disease. So we can, by doing this, we can target different nodes of the same pathway or different converging pathways, and it, at least theoretically, could suppress better the cell signaling, and this might result, hopefully, in better disease control, and we don't know, but hopefully better tolerability. So this is the second type of combination. Those combinations aid at improving the efficacy of ruxolitinib and try to modify the disease. And there is a very long list of candidates or drugs which are being tested in combination, including classical drugs such as interferon, also histone deacetylase inhibitor, HOT inhibitor, mTOR inhibitor, PI3K inhibitor, hypomethylating agent, and many other agents. These are the studies, the main studies currently in progress, combining ruxolitinib with panovinostat, Buparlisib, sonidegib, azacitidine, interferon alpha. And in the interest of time, I have selected some of them. For instance, this is the combination of ruxolitinib with panovinostat, a histone deacetylase inhibitor, and what we have seen in the preliminary results of the combination is that by combining this drug, we can achieve a greater effect on the spleen reduction, and in some patients, there is a suggestion of an improvement in the reduction in the allele burden. So this is a promising combination. We'll see what happens with more patients with longer follow-up. And this is a summary, first, of the use of panovinostat alone in myelofibrosis, and then of the combination. So there was some toxicity, which was the thrombocytopenia, and now we had the recommended dose, but as I have mentioned before, the study is ongoing, and we'll see the results with longer follow-up. Another combination is ruxolitinib with Buparlisib, which is a pan-PI3K inhibitor. And again, as it happened with the other drug, there is the combination results in a greater effect in the reduction of the spleen size. But when we look at what happened with the reduction in the JAK2 allele burden, we saw that the reduction was usually modest. There were individual patients in which there was a marked reduction, but if you look at the two arms, so patients with prior JAK inhibitor treatment, or no prior and prior JAK inhibitor treatment, in general, the reduction, at least with the available follow-up in the JAK2 allele burden, was modest. Another combination, sonidegib, which is a smoothed inhibitor. Again, the same effect. So this is the spleen, so greater spleen reduction, and concerning the JAK2 allele burden, not a clear effect and increasing the reduction. And in addition, there were some problems of side effects, chemotherapy-like, such as alopecia. And concerning the effect on the fibrosis, it was not very clear. So there was some patient with reduction, but in other patient, the fibrosis remained stable, and in other cases, there was a worsening of the fibrosis. So no clear effect on the JAK2, no clear effect on the fibrosis improvement. Other combination that I have selected is Ruxolitinib plus azacitidine. And according to the data from the Andy Anderson group that performed this study, the better combination is giving Ruxolitinib alone for 3 cycles. The cycles are of 4 weeks, and then administration of azacitidine after the 4th cycle, and after the 3 cycles, so starting on the 4th cycle, and then onwards. And this was what they obtained. So there were an effect. There were 2/3 of responses. The responses were very variable. In some cases, the spleen, the symptoms, and the anemia. In other cases, the spleen and symptoms, the symptoms and the hemoglobin. And in a high proportion of patients, only symptoms and only spleen. But if you look at what was most frequent is the reduction in the spleen. So apparently, it is a drug that combined with ruxolitinib can reduce further the spleen. Concerning the effect on the anemia, at least with the follow-up, there was no improvement in the anemia. So the median hemoglobin value was very similar at the beginning and after 24 weeks. So this would be a summary of the main combinations that I have selected. So in general, the combination usually results in a higher or greater effect on the reduction of the splenomegaly, but in some of the cases, there are some toxicity that is not sufficient to justify the combination. I have mentioned before the alopecia with sonidegib. I had mentioned also, I have not mentioned mucositis. I have mentioned the cytopenia, especially thrombocytopenia with panovinostat, also cytopenia with azacitidine, and concerning the combination with interferon. So the results are very preliminary, but apparently there was an increase in the neutropenia and the infection. So difficult to choose which is the good combination. We need more information, more combination, and longer follow-up. So in the interest of time, this is a short presentation. This will be my conclusion. We know that ruxolitinib is effective in the control of the spleen and the constitutional symptoms, but not the anemia. And there are no very clear indication of a disease-modifying effect apart from the certain survival prolongation. To try to improve the anemia, there are combinations with several anemia-treating agents. We don't know which will be the good one for the time being. And in order to achieve a real disease-modifying effect, there are combinations with ruxolitinib with agents with a different mechanism of action. And for the time being, we don't know which is the optimal candidate for the combination with ruxolitinib. So I think that this is my last slide, and thank you very much for your attention.